This was a real case where the surgeons call me and say, okay, we have this patient, she's cirrhotic, and they basically said patient has multiple metastases. Can you please help us? Do we really need the biopsy? So what you see is you see multiple lesions in this patient. And the reason it was called metastases is based on this lesion. So this particular lesion was described as having a targetoid appearance. It was described as having a targetoid appearance. You can see it does have a center which is distinct from the periphery. So, like so, right? And open up the diffusion. So based on this one lesion, which in the interpreting radiologist's opinion looked like a target, they said, well, you have multiple masses in this patient. At least one of them has, targetoid features, which is LRM. And if you read Lyrett's score, you know that one LRM feature is enough to categorize something LRM. So that's what they said. They said metastases.
Steve, is not the right targetoid look?
Correct. So I've never seen this example of this feature to be this prominent, but this is not a target, even though it does look like a target, right, where you have peripheral rim and the central something, but it actually not target. This is a nodule in nodule appearance. So this is the internal nodule within the background larger nodule. And if you look carefully at all other masses, now they demonstrate, or many of them demonstrate mosaic appearance, where you can see that, right? So you have multiple internal septi and compartments. So these features actually are specific for HCC. So this patient had multifocal HCC, and it was miscategorized. It was a very, very nice appearance of the what do you call it, mosaic appearance. But because of this was erroneously assumed to be a LRM feature, and this was misinterpreted as as metastases.
Steve is asking if any of them met LR5.
All of them meet LR5. This is LR5. This is LR5. Well, not
right,
all of them.
I mean, the one that was misinterpreted, why did they just disregard the fact that, or they called all the rest of them LR5 and that one LRM?
Well, I think that the way they kind of thought about it is that you have multiple masses, and one of them looks like, in the opinion of interpretive radiologists, this looked like a non-HCC malignancy. So I guess in their mind it was assumed that they assumed that the rest of them were following this, which I guess is a reasonable assumption.
Anu is asking, is the periphery fat on the in and out of phase, or what is causing that nodule and a nodule appearance?
So again, so the way this is an example of hepatocarcinogenesis where the nodule, right? The what do you call it? The you start out with a low-grade dysplastic nodule, you progress to high-grade dysplastic nodule. Then within the high-grade dysplastic nodule, you get little foci of clonal mutation and expansion, and that little clonal clump of cells will grow and turn into HCC. So it's not the entire dysplastic nodule that just goes bad, it's just part of it. And as that part grows, we can sometimes catch it in this nodule in nodule appearance where you see the background dysplastic nodule, and internally you see a more aggressive nodule, which represents, the progressed part that progressed to HCC. So generally, we just don't see the inner nodule to be almost the size of the outer nodule. Usually you see like a bigger nodule, and the internal nodule is much smaller. So it's clear that we're dealing with nodule appearance. But in this case, we just caught it at the time where the internal HCC almost completely replaced the underlying dysplastic nodule, just caught it at that particular time. So this was, oh, and this is another teaching point to complement the other case. Now this was, oh, by the way, AFP was through the roof, and that's really the reason why the surgeons contacted me, because they didn't want to biopsy this patient. They didn't have to. So notice how most of these masses are, mid criteria for 5, and very few of them have restricted diffusion, and none of them are brighter than a spleen. So that's the counterpoint to the other case, where a tiny little lesion was very, very restricted in diffusion, where you have these big HCCs, and majority of them don't really restrict. So this patient, so the patient didn't have to get a biopsy, and they just proceeded with treatment, and this was, based on imaging features, was presumed to be a, what do you call it, a multifocal HCC. That was just a good case. And you can see them here.
So pseudo-target sign.
Yeah, and you can actually see, very interestingly, there's a capsule around the inner nodule. So the inner nodule really is, a nice HCC, and somehow the outer nodule didn't get completely replaced by it yet. Okay. All right. So